It gives me great pleasure to, present my classmate and dearest colleague, Professor Ahmed Hassan Abdelaziz, who this is the Pfizer Symposium. Go ahead.
Thank you very much, May. Thank you for your excellent presentation.
Thank you.
And thanks for introducing me. I'm going to shift gears a little bit. So we're going to talk on lung cancer and specifically on EGFR mutated lung cancer. So lung cancer, although it is the top or the most common cause of cancer mortality worldwide, nevertheless, in Egypt, it is not the most, it is one of the most common, but it is not the most common. So it ranks around 4 in terms of incidence and in terms of mortality. What adds insult to the injury is that actually, as we have shown before working on our cohorts presenting to Ain Shams University, we studied patients presenting to our oncology department for 4 years to look at the stage of presentation, and we found that 75% of patients coming to our oncology department are metastatic. So 3/4 of the patients are metastatic, which is too bad. And almost all of the rest were stage 3. So advanced lung cancer patients constitute the largest group of patients we're seeing in our daily practice. And as regards EGFR, the incidence in Egypt, as shown by the two biggest studies, the first one from Dr. Amal Ibrahim, and the group around 2018, they demonstrated likelihood of 17.5%. Then another bigger paper by Dr. Rabab Ghaffar showed that the incidence is probably around the 22%. So we're talking about something between 17 to 22%. 1/5 of the patients will present with EGFR mutation in Egypt, which is slightly higher than in the West, particularly Europe, where it is hovering between 12 to 15%. Most of the mutations in Egyptians are exon 19 deletions, in keeping with the international literature. And the sad fact is, when I compared this paper from the National Cancer Institute to our data, I found actually the same exact figures. Patients going to National Cancer Institute, 3/4 of them were metastatic, and 20% were stage 3. If you look at stage 1 and 2 in Ain Shams or National Cancer Institute, they constitute 4%. So, which is really, we're doing really too bad in terms of early diagnosis and screening, and we need to focus in this dimension. And thanks to the better understanding of cell biology, we know that now big fraction of the patients have a driver mutation. Treatment were mainly planned according to histopathology. Now we're moving to histopathology agnostic treatments. We're looking at molecular mutations or genetic mutations rather than the histopathology. And we have a plethora of agents that are now available to our patients targeting the different mutations. So it is not a luxury now to test patients upon diagnosis for at least the big 5 or 6 most common mutations, including the EGFR and the ALK, as well as, of course, the ROS, the RET, and the MET. And in Egypt, we at least have treatments for 3 of these. As I say, the likelihood of EGFR mutation is around 12 to 15 in Europe, but the more you go east, the higher the likelihood. In Egypt, it's around the 20%. In Asia and in the Far East, it's reaching up to 40 to 50 sometimes %. The EGFR mutations, not only just one mutation, we have the exon 18, 19, 20, and 21. Some of them behave better than others. Exon 19 and 21, they constitute around 90% of the mutations, and the rest constitute 10%. How do they behave? They behave differently. One of the worst mutations is the exon 20, in which chemotherapy remains the standard of treatment. However, things are going to change very soon. EGFR 19 deletion, which is the most common mutation, actually is the most malignant, is more malignant than L858R, as you can see, the outcomes if you do not treat or if you treat with chemotherapy are worse than 21 exon mutations. However, cancer cells, lung cancer cells, are more addicted to the exon 19 rather than the exon 21 and more driven by the 19 rather than 21. And therefore, if you give an efficacious target, or if you target the exon 19 with an effective agent, you are likely to generate better responses. It's a story something like the HER2 positive, for example. It was one of the most adverse histopathologies in breast cancer, but once you have an effective treatment, you transform this outlook 180 degrees. So what happens to exon 19 deletion if you pick the right agent? For example, if you use anti-EGFR agent, you transform, as you can see, from the worst Kaplan-Meier outcomes to the best Kaplan-Meier outcomes. So exon 19 mutations, in a nutshell, they are more malignant. However, cancer cell is more addicted to exon 19. So if you target it, actually you achieve the best outcomes and you end up with progression-free survival and overall survival better than with L858R. And I have so many clinical trials to show you, showing you that if the patient has 19 deletion and you treat not with chemotherapy, but with anti-EGFR, regardless of the anti-EGFR, enlotinib, gefitinib, second line, third line, second generation, third generation, you achieve better results and better outcomes. We recognized the biology of non-small cell lung cancer back in 1993, hence started research, and this translated into the first prototype, which was gefitinib in 2003, and then we had the sequence of events with the introduction of the subsequent molecules that you all know. We can classify these into three major categories. First generation, second generation, third generation. First generation, erlotinib, gefitinib. Second generation, afatinib, dacomitinib, and third generation is osimertinib. First generation are reversible, second and third are irreversible. They are different in the molecules and in their pharmacokinetics and pharmacodynamics. But the higher the generation is, the better CNS penetration and the more irreversible the molecule is. The IPASS, the first study, showed that you can improve disease control, prolonged disease control by around 4 months with a hazard ratio of 0.48. The optimal study replicated the same, almost same impact, but the criticism to the two trials was that they were looking at Asian populations, which does not necessarily apply on the rest of the globe. Then we've had the IRTAC, and the IRTAC showed the same, so we have known and we have learned at that point that this class is effective across all different races, whether Asian or Caucasian or whatever race. Then came the same question that we have every time when we have two good molecules. We've seen this story several times: palbociclib, ribociclib, arimidex or femara, this or that better. And in this case, gefitinib versus erlotinib, two very good molecules in non-head-to-head comparisons. When they were compared, we observed the same efficacy. You can use the same this or that. Of course, there's different dosing, different practicalities, slightly different side effects, particularly in terms of skin toxicity. However, you can obtain the same results. These studies did not show overall survival difference, which was not convincing to many oncologists. Why shall I use a treatment when it does not improve overall survival? But the story is not like that. Most of the patients in these clinical trials were switched upon progression. So there was a switch upon progression. So essentially, most of the patients have had at some point of treatment the TKI. That's why we could not tell from these trials that there is overall survival. However, there are multiple real-world data to tell us indeed there is an overall survival in comparison with historical cohorts. Response rates, most of our patients are responding even to first generation TKIs. Roughly 8 out of 10 will have some, at least, disease control if you offer gefitinib or erlotinib. But things remained stagnant for a long time with the first generation until you can see the spike that happened around 2016 with the introduction of the second and third generation, and PFS, while it's kept dwelling around 11 months, it improved to 14.7 months, then to 19 months with the second and third generation, which was excellent news to our patients. Afatinib was the first in the second generation. There were many Lux-Lung trials. Lux-Lung 3 and 6 were comparing afatinib to chemotherapy, and they managed to show us improvement in progression-free survival in these patients. However, at that time, actually, gefitinib and erlotinib were standard of care. So it made sense to conduct a clinical trial to compare afatinib to gefitinib, which they have done, but they have done it on a small clinical trial, phase 2, not phase 3, and they compared afatinib to gefitinib in this smaller study. And despite the median progression-free survival was the same, but this was just 1 point measurement. It's always more accurate and more holistic to look at the hazard ratio. The hazard ratio is 0.74. So indeed, afatinib is superior to gefitinib. What about overall survival? This was a small study, phase 2, and it did not manage to show overall survival. Again, there was some crossover, so they could not demonstrate this. So afatinib versus gefitinib, it is superior in terms of response rates, progression-free survival, but it was a phase 2 medium-sized clinical trial. So we needed a phase 3 trial on third generation. And here we've had the Archer study, which looked at another molecule, the comitinib, and the comitinib is given as 45 milligram once daily or continuously. And this study was a phase 3 this time, and it randomized patients 1-to-1. Study size was around 500 patients roughly, and it was given to all patients, treatment naive, no CNS metastasis. And what they managed to demonstrate that the PFS, which was the primary endpoint, improved remarkably by 40%. So it improved from 9 to 15, roughly to 15 months, which is the primary endpoint. So it was definitely a massive leap forward in management of EGFR-mutated non-small cell lung cancer. So these are the Kaplan-Meier curves of the Archer 1050, showing the hazard ratio of 0.59, so 40% reduction in the risk of progression. Improvement was observed across all subgroups, almost all subgroups. In terms of overall survival, there was an improvement with a hazard ratio of 0.76. Patients lived longer by 8 months. So from 26 to 34 months, improvement by 8 months. So this is a randomized phase 3 trials, tick the box for overall survival and for progression-free survival in almost all subgroups. This is the 5-year overall survival. The previous one that I have shown is a 3-year result. In the 5-year update, we have seen that what you have gained in the 3 years, they managed to retain at 5 years. So the 8 months gain was maintained, improving survival from 34 to 42 months. So the comitinib was effective to improve PFS and overall survival. If we look at the subgroups, exon 19 and L858R, we find that it improved the results in both groups of patients. However, the amplitude of benefit was seen more in the exon 21, with a hazard ratio of 0.7. What if you reduce the dose? Does this impact the efficacy of the drug? Actually, there is a very good study which looked at that, and it negated this concern. It showed that if you reduce the dose because of whatever reason, usually it is toxicity, then you're still getting the same results. In fact, there was slight superiority in these patients, and there are some theories that patients who have more obvious side effects or higher grade side effects this could be used as a surrogate marker for response, and they attain better responses. Two things to remember about the side effects of dacomitinib, because they are quite pronounced with dacomitinib, the diarrhea and the skin rash. So you have to be careful. You have to spend good time counseling the patient. Preemptive measures indeed make a difference to the success you want to see with this molecule. So you have to educate patients how to care for their skin, use moisturizer creams, steroids if needed, Imodium, and well hydration for patients receiving this molecule. CNS efficacy, as I said before, with the second and third generation, we've seen much better penetration. Let me tell you that with the first generation, the concentration of gefitinib or erlotinib in the CNS is 10% of that in the serum. With the second and third generation, it's much higher than that, approaching 90%. So that's why sometimes actually we drop radiotherapy from the package when we see patients with small non-symptomatic brain metastasis if they're receiving second and third generation. Here are some examples of how dacomitinib improved the metastasis over time. Objective response rates for brain metastasis are 90%. So 90% improvement in the brain metastasis, and the remaining 10% they get a stable disease. So 100% of the patients will have durable control of their CNS diseases. If you want to reduce the dose of dacomitinib for whatever side effect, it's always 15 milligram increments. So you step down from 45 to 30 and from 30 to 15 milligrams. What about third generation? Well, we are all aware of osimertinib and the data of the third generation, indeed very efficacious. They are irreversible. They target exon 19 and L858. They've actually been tested exclusively in these mutations, and they've showed high efficacy, whether in the first line or the second line, whether it's a EGFR mutation or a T790 mutation. I think you've seen this several times over the past few years. The FLORA trial, randomized control trial, again around more than 500 patients, randomized patients to osimertinib, 80 milligram or first generation, and we've seen how it improved the PFS and the overall survival of patients. Impressive results indeed. This led to osimertinib to be, I think, the most commonly used anti-EGFR nowadays. The hazard ratio for PFS was 0.46, and for the overall survival it was 0.8. We've seen efficacy in terms of PFS in both mutations, exon 19 and exon 21. However, if you look at exon 21 with the hazard ratio, this was not different in exon 21 mutation. But bear in mind that overall survival is a secondary endpoint, and this is a subgroup analysis. I'll just skip for the sake of time, but we have now, I've discussed two effective molecules, one second generation and one third generation, how they compare. Of course, it's not very accurate to compare non-head-to-head clinical trials. Why? Because they are different patients, different hospitals, different investigators, different care. So it's not very accurate to compare. However, sometimes if we don't have other means of comparison, we rely on the non-head-to-head comparison. So in terms of PFS, we have hazard ratio, it's osimertinib 0.46. It is 0.59 in the dacomitinib. So 40% improvement with second generation dacomitinib, 50-something% with osimertinib. These are the hazard ratios. What about overall survival? Overall survival, the hazard ratio for osimertinib was 0.8. For dacomitinib, it was 0.76. Here, I want to draw your attention to something in this Kaplan-Meier. If you look at, just disregard dacomitinib and osimertinib and look at the standard of care in both groups, those who had gefitinib, you will notice that in the dacomitinib study, in the Archer trial, this was a worse quality of patients because their median survival was 26 months, unlike the patients in the FLORA study where they lived in average 32 months. So this is why we're seeing these probably lower Kaplan-Meier curves. So the dacomitinib was tested in a more harsh environment, if one can call it. But the hazard ratio in both is very convincing. I have few more slides. So can you? So this is the ASCO recommendation as well as the other society guidelines, which recommend osimertinib as the preferred line of treatment because it was the most studied and it has the biggest data. However, in patients who do not have access to EGFR mutation, they ask, for example, another guidelines say that another very acceptable, very efficacious option is the dacomitinib as monotherapy. If you don't have any of these, then you can combine first generation with VEGF, anti-VEGF therapy. If you don't have access to any of these, at least offer first generation TKI. But we're in Egypt, as the rest of the world, cost effectiveness is of paramount importance. Even in America, where they have very supported environment financially to offer whatever they like. However, cost effectiveness is very important. Here is the list, for example, published by the ASCO for the prices of these agents, and you see that erlotinib and gefitinib are much cheaper than the third generation, and the dacomitinib is somewhere in the middle. Cost effectiveness is very important. For those of you who do not know the cost, I asked Pfizer about the cost because I'm new to this drug as well. Visimpro is available in the private for $30,000. However, the price at the UPA is $12,900, which is very impressive. And actually, although my main practice has been with osimertinib, but actually for patients who cannot afford this, I will really seriously consider using Visimpro because the price difference is quite convincing. I've done this slide which demonstrates my point of view. In terms of efficacy, you have osimertinib and dacomitinib. I can put them together in one category, far from the first generation in terms of efficacy. The hazard ratio of PFS, yes, it is higher with osimertinib, but both are much better than the first generation. In terms of cost balance, in this case, in terms of cost, dacomitinib is actually, you can classify it with the first generation rather than the third generation. So in a nutshell, in terms of efficacy, dacomitinib is closer to the third generation. In terms of the price, dacomitinib is closer to the first generation, which is convincing to many patients, particularly those who cannot afford the third generation. In the UPA, the price of gefitinib, whether the originator or the generic, is something between $3,600 to $15,000. Dacomitinib is $12,900, so it's close actually to the first generation. Osimertinib is way further, it's $51,000. So honestly, if I put aside all the finance, all the money, if I have all the luxury, if all the treatments are distributed for free, I will opt for osimertinib because it has bigger data. First, second line, now adjuvant, neoadjuvant. It has very good CNS efficacy as well. However, if money comes into the discussion, into the talk, and it always comes into the talk, then I might consider dacomitinib because it has a very high efficacy, has a ratio 0.6, and at the same time, it spares a lot of cost, particularly if you get it from a provider of the molecule through the UPA, for example, in Shams's specialized hospital. Take-home messages: EGFR mutation-driven non-small cell lung cancer constitute 20% of the Egyptian population. They are standard now, and you should consider third line or second line. If you don't have access, then first line at least. Dacomitinib was superior to gefitinib in randomized phase 3 clinical trial, the Archer 1050, in both PFS and overall survival. Dacomitinib can fill a needed gap in the Egyptian practice, having a good balance between cost and efficacy. Thank you very much.
Dr. Ahmed, thank you so much, addressing a very important issue related to targeted mutation in lung cancer. Now, in the market, we have first, second, and third generation. We have a financial crisis. We have some data supporting survival benefit and prolonged PFS to the first time to be seen in metastatic bronchogenic who carry this mutation. Your opinion, what are the criteria in your decision, especially a second line shows some activity in CNS, right? In ARCHES. Your comment, please.
Well, definitely, if a patient comes with a CNS metastasis, I would rather give a third generation or second generation over first generation, because, as I said, there is very good Japanese research into this area, and the group showed that, as I say, the active amount of the IC50, or the active amount of the concentration of the drug that reaches the CSF and the CNS is 10% with the first generation. This is 90% with the second and the third generation. So we should be using, if you don't have access, we don't have access. And in this case, I'll use first generation and do some radiotherapy or localized treatment to the brain. If patients doesn't have a CNS, my preference is for osimertinib, although it is a Pfizer Symposium, but honestly, I use osimertinib for two reasons. The first reason is that I'm more used to it. I've been using it for a long time, that's one thing. The other thing is that the data is bigger. We have multiple clinical trials. But what I want to say is where dacomitinib can fit in this dilemma, it can fit where patients do not have access to osimertinib. Because the price difference, if we talk cost effectiveness, the cost effectiveness indeed is in favor of dacomitinib. Thank you.
I'd like to thank Dr. Ahmed. Very interesting, comprehensive presentation as usual, Ahmed. Thank you so much. دلوقتي هنقول for presidential initiative session، ودي حضراتكم احنا بنعتبرها من اهم المحاضرات اللي في المؤتمر كله، لان خدمة عيالنا هو الايم، فاحنا we will call for the next session.